Anorexia is defined by people who engage in self-starvation, express intense fear of weight gain, and have a disturbance in self-evaluation. It is also important for these people to maintain a healthy weight for electrolyte balance, protection of vital organs, and being able to hold their body structure up. Bulimia nervosa is repeated episodes of binge eating followed by inappropriate compensating behaviors such as self-induced vomiting, misuse of laxatives, diuretics, or other medications, and fasting or excessive exercise. Lastly, binge eating disorder is the engagement of repeated episodes of intense eating, significant amounts of food in a short amount of time. After this episode, they experience significant distress or guilt. One key note is that they do not regularly use compensating behaviors as seen in bulimia or anorexia. Binge eaters are not always people who are overweight either.
Myself again today, and the worst part is there's no one else to blame. Be my friend and hold me, wrap me up. I've lost myself again. Lost myself and I am nowhere to be found. Yeah, I think that I might break. I've lost myself again and I feel unsafe. Be my friend. Hold me, wrap me up. Unfold me, I am small. I need you, warm me up. And bring me, be my friend. Hold me, wrap me up. Unfold me, I am small. I need you, warm me up. And breathe me.
People with eating disorders have cognitive distortions that are the result of processing errors in the brain. Box 14.4 on page 237 shows examples of cognitive distortions related to eating disorders. Important to determine which cognitive distortions were present before the eating disorder and which ones are the result of semi-starvation. Eating disorders are connected to the underlying emotions of anxiety, dysphoria, low self-esteem, feelings of lack of self-control, and for many young people, eating disorders gives them something that they have the ability to control. Often parents don't realize it until the child is in front of them one day and they realize that this disorder is out of control. The teen or the child may be emaciated and they didn't realize it just because of busy schedules. Eating disorders are often seen in teens and young children that were sexually abused, have abusive parents, or in some cases of domestic violence as well. Culture and social norms directly influence eating disorder prevalence. Anorexia appears in early to middle adolescence when teens are influenced by models, magazines, and peers to be thin. Bulimia appears in later adolescence and can occur in women aged 35 to 65. Changes in appearance and role potentially increase the risk for these disorders. The actual number of individuals with eating disorders is unknown because disorders may exist for a long time before the person actually seeks help. More than 50% of people with anorexia and 95% of people with bulimia have one other psychiatric disorder. Significant comorbidities include mood and anxiety disorders, substance abuse, body dysmorphic disorder, impulse control disorders, and personality disorders, especially borderline and obsessive compulsive personality. Athletes have increased incidence of eating disorders now. It is now being seen in men more than ever, which may tie largely in with the athlete stigma. Biological vulnerability is activated by psychological, environmental, and cultural factors. The neurobiologic and neuroendocrine models are in regards to the chicken or the egg theory. We know that the issues exist, but which one came first? We know that serotonin pathways are abnormal in anorexia and bulimia, but could this be why the distorted body image and anxiety happen, or did they become largely skewed due to the changes in the body? Lastly, genetic factors do contribute to development of eating disorders. There is a 70% rate in identical and 20% rate in non-identical twins. Also, female relatives are up to 12 times more likely to develop eating disorders than their male counterparts. Low self-esteem and self-doubt of personal worth may lead to harsh self-judgment focusing on a patient's weight. Family theorists believe family dynamics lead to eating disorders. With anorexia, it's controlling, emphasizing perfection, achievement, and compliance. With bulimia, there's this chaotic, emotionally expressive conflict and negativity. Critics say genetic makeup may be strongly related to the disorder, but the Academy of Eating Disorders strongly opposes the theoretical model and that states that family dynamics are the primary cause of eating disorders. They focus on the fact that it could be largely related to depression. When patients with anorexia are hospitalized, you'll typically see many of the findings on this slide. Lanugo is a fine, downy type of hair on the body. The body grows this type of hair to help insulate. This is a trait exclusively seen on anorexics and usually develops after a very sharp decline in weight. Keratonemia is one of the first signs you will note in a yellowish pigment of the skin. You'll see this a lot with people that eat like almost a strict diet of squash and carrots, anything with carotene in the food. You'll note on the picture, this is a perfect example of a cognitive distortion. They call it body dysmorphic disorder. Assessments of those with eating disorders will include perception of the problem, eating habits, history of dieting, both failed and successful, methods used to achieve goal weight, value attached to the shape and weight of their body, interpersonal and social functioning, and mental status. Table 14.1 on page 237 in your book has interventions with rationales related to anorexia. Physical criteria for hospitalization of anorexia or bulimia includes a weight loss of more than 30% of the body weight within a 6-month period, temperatures below 36 degrees Celsius or hypothermia, heart rate less than 40 beats per minute, and systolic blood pressure less than 70 millimeters of mercury. Trust must be established for the nurse to obtain needed information. The patient experiences extreme fear of gaining weight. These patients are often unwilling to cooperate and are brought by a family member against their will. Outcomes need to be measurable and include a time estimate for attainment. 3 main goals for all eating disorders include restoring the patient's nutritional state. For anorexia nervosa, this means restoring weight within normal range, and for bulimia, it means to ensure a balanced metabolic state. Second, modify the patient's distorted eating behaviors. And last, help change distorted and erroneous beliefs about weight loss and body image. Russell's sign is seen as scarring and calluses that often build up on the lower knuckles of a bulimic individual. This is from inserting the fingers into the mouth to simulate vomiting. Prominent parotid glands and dental erosion are associated with vomiting due to the gastric acid constantly being erupted into the mouth. And also you're going to see a slightly above or below ideal body weight. Problems resulting from purging are a first priority because electrolyte and fluid balance and cardiac function are affected due to the fluctuation of potassium and sodium levels. Hypokalemia results from potassium loss associated with vomiting, and the sodium levels are affected mainly just due to dehydration from vomiting. For most patients with bulimia, certain situations trigger the urge to binge, then the purging follows after. Triggers are often anxiety-producing situations. Identifying these triggers makes it possible to break the binge-purge cycle. This is a priority for these types of patients as well. As with anorexia, the patient with bulimia may be treated for life-threatening complications such as electrolyte balance and cardiac dysrhythmias in an acute care setting, such as the hospital. Gastric rupture is a potentially fatal complication related to eating disorders where there's a spontaneous rupture of the stomach lining, resulting in a severe distension of the abdomen. And although the rupture is rare, it does occur. Table 14.2 on page 241 shows interventions for the bulimic patient. A cognitive behavioral approach is the most effective treatment for bulimia nervosa, as it helps to diminish errors in thinking and perception. Patients with bulimia often undergo various therapies because of possible coexisting depression, substance abuse, and personality disorders. Therapeutic alliance is established easier as the behavior is not what they want. It is imperative that irrational attitudes and perceptions of weight and shape be addressed. Therefore, restructuring faulty perceptions and helping individuals develop accepting attitudes towards themselves and their bodies is a primary focus of therapy. Nurses and nutritionists must educate patients with meal planning, healthy diet and exercise, relaxation techniques, knowledge of physical and emotional effects of purging, and the physiological effects of the eating disorders, and what kind of effects they have on the body itself. One goal of health promotion teaching is the normalization of eating habits. Food restriction and skipping meals leads to rebound binging and increased guilt. Times of starvation will also slow the metabolism to ensure the body can maintain any fat it consumes for the famine that it believes is occurring. Binge eating disorder is characterized by compulsive overeating, in which people consume huge amounts of food in a small amount of time. They begin to feel out of control and powerless to stop themselves. The symptoms of binge eating disorders usually begin in late adolescence or early adulthood, often after a major fail in a diet. Binge eating disorder is a variant of compulsive overeating. There are recurrent episodes of eating a large amount of food in a short amount of time, and usually leaves the person feeling guilty or shameful after binging. There are no compensatory mechanisms such as those in bulimia. High rates of mood disorders and personality disorders are found among binge eaters as well. A history of major depression is seen significantly more often than non-binge eaters. They also report that the binging episode is soothing and helps to regulate their moods. Effective treatment, such as cognitive therapy, medications, and family therapy, also work very well. It is important to integrate modification of the disordered eating with reported events and associated mood changes. This means that if the patient states that they feel a certain way with eating or that the mood changes occurred with the meal or before the meal, how can we then modify this pattern? We are always looking for ways to work towards the ultimate goal of a more appropriate weight for the individual. So a lot of times you want to include the patient on that plan so that they feel like they have some sort of control. Top-line treatment for anorexia is olanzapine or Zyprexa. It's a second-generation antipsychotic increasingly being reported in the literature. It has been shown to affect weight gain and improve cognition and body image. Bulimia is frequently treated with fluoxetine or Prozac. It's been approved by the FDA for the treatment of bulimia and has been regarded as the gold standard in the treatment of this disorder. Either alone or in combination with other behavioral treatments, binge eating and purging behaviors are noted to be significantly decreased, but you must watch for suicidal ideations in any patient taking an antipsychotic. Binge eating disorder does not have any pharmaceutical therapies that are approved yet by the FDA, but many doctors have been looking at Vyvanse. Vyvanse is thought to help control binge eating episodes, but it is not meant to help the binge eater lose weight. Patients may feel shame and totally out of control by the time they are hospitalized. A therapeutic alliance shows empathy with the feelings of low self-esteem, unworthiness, and dysphoria. The nurse may suspect dishonesty when the patient does not report binging or purging. Bulimics are very sensitive to the perception of others, so when caring for the patient with an eating disorder, accepting attitudes and having a non-judgmental approach combined with the understanding of the subject experience will help to build trust between the nurse and the patient. Nurses find it difficult to take eating disorders seriously. Many believe that it is a chosen behavior that the patient can stop it at any time. They will also blame the patient. And unless the nurse has dealt personally with this disease or have a family member with the disease, this perception often remains. Review Box 14-4, Cognitive Distortions Related to Eating Disorders, on page 237.